So welcome everyone. I'm Sue Goldie, and I have the distinct honor of welcoming all of you to what I hope will be, oh, there's a baby, a terrific evening, both of celebration, of optimism, and a little bit maybe of leaving with our sleeves rolled up. Paul asked me to say a few words about the Harvard Global Health Institute, which in a prior iterations of is where some of the initial kernels of some of the work of this book not began, I won't say, but took hold. And also what the connections are between the Institute and some of what we're going to talk about tonight. And then finally, what may be the shared platform is. So I was just going to say a few words about each of those. So the first thing is I won't say what is global health, because that's going to be discussed a lot tonight. And for all of you that have read the book, you know there's no clear answer to that. But who are the global health constituencies at Harvard? I think of them as three. One is the foundation of all of the individuals in the medical school, and the school of public health, and the teaching hospitals. In large part, that's where the individuals that have dedicated their lives to global health reside. There's also a broad university landscape of folks very interested and invested in health and a global perspective, and some of them hang out in regional centers, and some congregate around problems in theme-issued centers and institutes, but a large constituency. And then third, a thread through both of those is this incredible pool of students and trainees, some of whom are passionate about social justice in general, and some who want to dedicate their lives to global health. In that vein, there's been a number of iterations of university commitment to global health. And Paul, as well as many of the people in this room, and I have had the privilege of being a part of a lot of those. And like all complex social phenomena, there were ups and downs and different directions and a mosaic of motivations and varying degrees of success. But the thread that persisted through all of those efforts was a passion and a commitment to education and to that next generation. And that piece, I think, has not only sustained, but that's the building block of what the Harvard Global Health Institute, formed by President Faust 2 years ago, is based on. Paul Farmer, David Cutler, and I have all had the honor of having a role in that institute. And I think, as Paul alluded to in the introduction to this book, around that time that the university was thinking about what will we do as a university, there was a lot of fervor, global health fervor, around the country, especially in academic institutions, and lots of activities ongoing. And one of the questions that permeated lots of our discussions was, well, there's a bunch of pragmatic questions. What are these activities? Is this really what the faculty and students want? Are the resources there? Is it sustainable? And then there were more fundamental principled questions. Are these kinds of activities that universities are engaged in reflective of the consequences, positive and negative, that we would hope for? And do they reflect the values that we all have? And that required a bit of thinking. So how do you construct a university-wide institute that adds value, but that also harmonizes the set of values we all think are important? I won't speak about those, but I'll say three words that I think will give you a sense of what that motivation was. So first word is people. Not problems, not projects, but people. So an analytic perspective, whether that's qualitative or quantitative, that focuses on people as the center, families, communities, and populations, was first and foremost one of those underlying pieces. Second word is not going to be a surprise here, it's equity. And that sense that the health of individuals and populations is in a complex social context, but it's not only the health, it's the distribution of health, and it's really the commitment to having that look different, that we consider it university-wide, that should be a principle. And third, it's one world. It's not two, it's not three. It's not as simple as problems flowing one way and solutions flowing the other. It's not interdependence. We are one world. We are interconnected. We have a set of shared values. We do have lots of new problems, but that one truth is the same. The Institute does focus on a lot of the global forces and dynamic shifts in population that are occurring, but the principle that the negative consequences of those global risks are felt disproportionately by the worst off, and the benefits of all the progress we've made, both knowledge-related, scientific, technical, is preferentially experienced by the best off. With those three guiding principles, how do we create a set of activities and commitments that really lends itself to where we would like to be? And then I'll close with just saying a couple of words about the Institute itself. And I'll summarize it in three quick lines, motivated by sort of what we need. So, new kinds of leaders. And much of what you'll hear about tonight is the fabric of new global health leaders. And some of the broader areas that we focus on at the university-wide level is new global leaders who value health. So we need both. We need global health leaders, we need leaders who value health, we need influential change agents who share our social values. And that's going to require a change and really a transformation in what we teach, how we teach, and who we teach with. So much of what we do at the Institute is thinking about piloting and incubating educational, both pedagogy and public goods. The second piece is new kinds of knowledge. And I don't mean that it's all new problems, but there are old knowledge gaps that we should be able to solve. We've illuminated gaps such as health systems, such as contextualization, such as delivery, that we can now articulate, but we haven't solved. And then there are indeed new problems as a product of the complicated world we live in. So how do we, as a university, contribute in a way that respects a process of co-production of public goods and new knowledge, of linking that new knowledge to making a difference, whether that's policy or whether that's service, to aligning that with the process of translation, and to doing it in the context of principled partnerships. So at the Institute, that may involve creating intellectual hubs where the kinds of activity to keep complex issues complex and have a dialogue across disciplines happens. And you'll hear tonight about other areas where the fabric of actually tackling those problems is happening on the ground. And then the third area that I'll close with is the notion of public goods. So we throw that around a lot. What are knowledge-related public goods? And I'll just say that, my own opinion, sitting in a university seat, the knowledge divide is probably the place the university has the most responsibility to affect a different look in 10, 20, 30 years. That issue that we don't have hubs where we balkanize things and restrict the benefits of knowledge is a place the university can really forge and make a big change. I always say, if a book is really, really good, it causes you to argue with yourself. And so I read the book a couple of times. It's long, so only twice. And I found myself, I always love the way my field of decision science, of which I do not do cost effectiveness analysis. However, because in decision models we use costs and use effects, I feel like all the time if I read stuff from this group, I'm like getting attacked. However, we've kind of come to this symbiotic relationship that I use the tools, but it's not the underlying theory. So you can also use cost effectiveness analysis to insist on equity and make the constraint, the thing you manipulate, the issue of cost. But that all being said, the controversy I found myself gravitating to in the new ways I was thinking was in chapter 10, which I was actually surprised, because I usually don't hear Paul and his colleagues talk a lot about accompaniment in the context of institutions as much as I've gravitated to accompaniment in the context of individuals and communities and the whole underlying notion of care. And what I thought about is what I take away is, can I think harder? Can we think harder about accompaniment as a university? And how that would look if it happened with the same goals and the underlying principles and a vision, but was true accompaniment. So I'm going to end with that. I am so honored to be able to launch the celebration of this book, which I will say is not a book like a finished product. It's in the middle of a dynamic process that asks questions and really begs us not to oversimplify, or we're not going to ever find the answers. So I'll end with that, and let me turn it over to, I think Matt is our next speaker.
Well, thank you, Sue, and thank you all so much for coming today and allowing me this opportunity to talk, which I will keep brief in order that we might hear from our more distinguished guests. My name is Matthew Basilico. I am currently a MD and PhD student in economics here at Harvard. I'm also proud to be a resident tutor at Adams House with my wife, Marguerite. And I was a social studies major here at the college. Before I begin, I just want to, with any project that's as big as this, there's an incredible amount of thank yous, and we have several pages of them in the book, but there's a few that I just can't go without mentioning here, since several of them in the audience. First of all, Emily Bonson, Jen Puccetti, Cassia Vanderhoof-Holstein, Marilyn Goodrich, and Vicky K. I'm going to butcher your name, so let's leave it Vicky K. This would, as well as anyone, this would be nowhere without your continued guidance through so many, through earthquakes, through all the challenges, through 5 years of this course, and that perseverance and investment in this project while there's so many other things going on was invaluable. So thank you. There's an incredible diversity of teaching fellows that have taught with the course and made it the incredible thing that it is. I wanted to specifically mention Emily Harrison and April Opeliner, Jason Silverstein and Jan Walter, who are taking it over this year, and Jessica Perkins, who have been head teaching fellows for this course over the past several years and have done just a phenomenal job. Also, of course, Ann and Salman, Jim leaving obviously left a big void in this class, but you've more than filled it and transformed it into what it is today. The final two people I want to mention in terms of the book are two people that just had such an incredible impact, and that's John Weigel and Luke Messick. So Luke can't be here, but John's sitting here in the front. And you'll see John's name scattered throughout chapter 10, which Sue just mentioned. He's the first author on, and but his contributions have gone far beyond that. And I'm very glad that we're now standing here with this book completed, which I think there are times that the three of us didn't think that would happen. But thank you.
Blasphemy.
And finally, I want to thank my parents who are sitting in the front row. There's no words to describe the blessing that I feel to have grown up with you. And finally, my wife, Marguerite, the love of my life. And of all of the privileges of my life, there's nothing greater than being married to you. So I thought I would just take a step back and talk a bit about how this book came together and the course. And yeah, sorry for doing all that. This is probably the only time I'm going to speak at a major event in several years, so I guess I have to. This all came together in the summer of 2008 when there was a number of years where I think Paul and Jim and Arthur have been approached about, it'd be great if you would teach an undergraduate course, and I guess there have been reasons this has been delayed, and so I was working for Jim, and Paul and Jim said, well, can we try it this year? And I said I'd be happy to give it a chance, and I was very fortunate to be asked. The syllabus went through many iterations and learned an incredible amount in that process, and really we didn't know how the course would go, and to our surprise, perhaps, or but maybe not such a surprise when you have such an all-star team of lecturers. It went really well, and in terms of the Q Guide ratings that we got. But one of the pieces of feedback that we kept on getting was that students were like, well, I really love what's being said in the lectures, but the mapping between the reading materials and the lectures, there's some gaps there, and we realized that kind of making this this journey between social theory, history, and applying those concepts to the problems that they're facing is something that's very challenging, and we thought it'd be great if we could kind of textualize that. And we also wanted this. We realized that there's a gap for people that get interested in global health, and then they're like, okay, well, what's the next step? How can I learn more about this area? And so we thought that a work could fill that gap. So we tried to make it both readable and academically rigorous at the level of the course, and this is what we have, and you can be the judge. So I think I'm a bit too close to the book to say anything like really substantive about it at the moment. I saw Paul at the first lecture of SW25 this year, and it was the book was finally done. And he comes up to me, he's like, he basically critiqued me because the index has all lots of flaws, and so I went home I went home very sad, and then I'm just because I know that you had mentioned it, so I went home very sad, but luckily, luckily my wife was like, well, if Paul Farmer's only critique is the index, I think you've actually done a pretty good job. I think it's actually been like a success. And then so I felt better for like 3 days until I was talking to Luke about Luke Messick, about something very different. He was like, oh, the way when I pick up any book, I start with the index. And that's how I decide whether this is going to be worthwhile or not. So, I promise we'll work on for the next printing. I think we're given like 2 days to turn it around. So this is something. It is a work in progress, but so anyways, instead I'll share some reflections on the often nebulous idea of global health that have come from the past several months, which for me have been an interesting traverse between clinical medicine, consulting the President's Office, the World Bank, doing ethnography with a historian of science in rural Malawi, and now back to my economics training here at Harvard. Global health is, in fact, a deeply empirical endeavor. This may seem an odd statement, as strong empirics is something that we usually associate with established social sciences and particular methodologies. Econometrics has many strengths in its ability to measure the relationship between mathematical models and socially collected data. As economists, however, we face major limitations of the human species' facility with math, and the functional forms we estimate often fall far from the social processes that they attempt to describe. For others, a staple of empiricism is the ethnographic method, with its attention to local knowledge and human experience. Yet the ethnographic method faces limits that include subjectivity, replicability, generalizability. Even more broadly, historians of science remind us that the methodological landscape has demonstrated significant dynamic instability, continuously shifting in unforeseen ways over time. Truth claims of a discipline shift across eras. Several decades from now, will the truth claims underpinning our most respected forms of analysis appear as antiquated as those of Levi Strauss, Parsons, or Keynes appear to us today? Probably. Global health begins with something that I would argue is actually more basic. As a human on this earth, it seems unreasonable that certain things should be as they are. That some should die for want of care that costs but a few dollars, or that some should face serious morbidity simply because of the geography of their birth. This notion is perhaps one of the deep truths about human existence in the current era, and is one thing that unifies the field of global health among its myriad of participants. When other analyses say that given XYZ reasons, this social theory, this functional form, it makes sense that many should suffer and die needlessly, there's something in our being that says, this cannot be right. Often it turns out that this instinct is in fact correct, even judged by that particular truth claims within a discipline. Colonial medical theories of the disease native, or even highly cited 2002 estimates of the cost effectiveness of AIDS treatment versus prevention, have been overturned by the very disciplines that shape them. But regardless of the time horizon upon which these immodest claims of causality are revised, we all look for empirics that will stand beyond the structures that shape the discourse of the day. This is precisely where I believe global health has its deepest hold, to connect us to our contemporary social world in a way that transcends, as much as we may ever be able to, the social constructions that shape our lives and our process of reason. To me, this is also what explains the enduring appeal of the archetype of Paul Farmer, who I understand this person sitting here has some resemblance to. Why should not everyone, everywhere, have a decent chance at a decent life? What the field of global health argues, which is so well articulated by the journey of this particular thought leader, is that there's no enduring answer to this question. Instead, we find academic legitimacy in a stance towards equity, which Sue Goldie mentioned earlier. We're therefore drawn to the practical dimensions of our present reality. Endeavors range from defining challenges to adapting technologies to optimizing interventions. Work in this field is often evaluated by the simple question, does this work? The field's participants are perennially challenged by steep gradients of power inequity, distortions of reason through our interest-shaped socialization, and opaque, self-serving, albeit human, motivations of corporate and state and civil society actors. Participation, for example, can mean either a step towards equity or a meaningless buzzword or many other things. But rather than shying away from complexity, the field has embraced it and learned from it. This textbook and a course are a testament to the ability of global healthists, at least those of a particular training trajectory, to reflect deeply upon the experiences of the past, from colonial medicine to the Washington Consensus, to integrate theoretical perspectives of important social thinkers, from Weber to Foucault, and to take local knowledge and experience seriously through the work of leading ethnographers, and incorporate these frameworks in support of contemporary social action. With this practical stance towards global health equity, one will inevitably hear the comment, this can't be done. We have already established that there is no real answer to the question of why the distribution of death and suffering should be as it is. So someone telling you you can't do anything is not a legitimate answer. It is actually in precisely these situations, imagining and implementing practical solutions in the face of skeptical conventional wisdom, that rich biosocial analysis provides a helpful vantage point. The study of the past reminds us of the many times in which the idea of what was possible is redefined. I'll just recount one story for you. There are several in the book, but to mention one that appears in chapter 5, the story of HIV, which I'm sure, and the AIDS treatment rollout over the past decade, which might be familiar to many of you. But if we just take a snapshot around the year 2000, AIDS treatment was available or had been created in the global north. In the developing world, less than 50,000 people were on AIDS treatment in 2000. In terms of arguments about whether treatment could be provided in developing countries, you had, for example, the head of USAID saying that people in rural Africa cannot take drugs because they do not know what watches and clocks are. They do not use a Western means for telling time. And this wasn't just one person. The fact that he was head of AID and giving this in a testimony before Congress kind of reflects the conventional wisdom of the moment to some degree that he was able to make that statement. The cost of AIDS treatment was $10,000 per person per year. There was an article in The Lancet that I mentioned earlier. Prevention is 28 times more cost effective than treatment. People said that health infrastructure is too poor. They said that there just aren't enough resources available to do AIDS treatment in developing countries. And conventional wisdom was that AIDS treatment could not be done in the developing world on a large scale basis. And I'll just snap to today where, according to the United Nations, approximately 10 million people are now on treatment for AIDS in the developing world. And the cost of treatment is now under $100 per person per year, down from $10,000. Some of the highest rates of adherence to medicines have been recorded in resource-poor settings. There was a randomized controlled trial which showed that treatment is in fact prevention, as someone with HIV is 96% less likely to transmit the disease to a partner if they're on treatment. And perhaps the real kicker, between 1998 and 2007, development assistance for health increased from 8.5 billion to 22 billion. And so this argument about, well, the resources aren't available, obviously took on a very different meaning when the resources were in fact expanding greatly. In this situation, the very definition of what was possible was redefined, and it was redefined against the prevailing conventional wisdom, or reimagined, as I guess the textbook title says. So what does all this tell us? From a sociology of knowledge perspective, conventional wisdom is at odds with reality. Even when they're coming with from credible academic or institutional sources, the assumptions, parameterization may indeed be inaccurate, precisely in the direction of justifying why needless suffering and death should occur. At the very least, the approach we take to global health in the present book should help us interrogate the conventional wisdom of our day, our claims of causality, and reimagine the possible in the health of the poor. Before I end, I just want to touch on one other topic that comes out in the book, and that's of mentorship. As you'll notice from the list of authors and co-authors, Arthur Kleinman was the mentor of Paul and Jim in their PhD programs and starting before. But that relationship certainly did not end in the least after their training was over, and he's in fact remained a lifelong mentor and co-teacher to them. Actually, Howard Hyatt is also standing who's in this audience, has again been a lifelong mentor towards so many of these incredible thought leaders that are joining us today. In my own case, I've been incredibly fortunate to have some of the people up front here among my mentors, but of course the fact that I call Paul Farmer and Jim Kim among my mentors means I can only be a disappointment to the world. But one thing I would say that you do realize is that with really outstanding mentorship, you can never repay. Even if you spend 5 years working on a textbook, you will not repay this kind of mentorship. But there is one thing that you learn that you can do, which is passing it forward. And so I would, just as a quick plug, this is my wife and I are in Adams, and we love the tutoring that we do, and of course open to Adams students. Really, anyone who's undergrad or whatever at the university, if you ever want to talk about something, we're there. But also, this was really a big motivation for writing the book, and it was to spread the analytical rigor and lessons of the mentorship that we've been so privileged to have here at Harvard from all the people that you will subsequently hear from, and to improve the access to these intellectual resources beyond the walls of this particular institution. On this theme of mentorship, it's my great pleasure to introduce to you my mentor, and someone who, in addition to his unwavering commitment to move global health equity forward during his lifetime, has still somehow managed to find the time to be a mentor, guide, supporter, and good friend to many of us sitting here in this room right now. I'm pleased to introduce Paul Farmer.
Thank you. And no, Matt, you cannot repay. You're just beginning to pay. And now that you'll be paying more in the future. I'm going to keep my remarks very brief, and I'm not going to talk about the book, and I'm not going to talk about biosocial analysis because maybe we want to save some time for discussion. And other people can illustrate this. What are you laughing about already, Salman? As you can tell, we're all a close group, a group of close friends. Our lives entwined for a very long time. And before I forget, because Arthur and Jim aren't here, Arthur is out of the country. Jim's probably out of the country too. And I know they are joining me and us in our thanks. Especially, if I may, thank all the teaching fellows and faculty and students, and all of the network of friends in the faculty or in some of the places where we work. I just saw Michael Rich come in, who is a physician, Partners in Health physician, who has been very welcoming of students and trainees. And Matt made a beautiful tribute to mentorship. Mentorship, of course, goes both ways. Students teach us, just as it goes both ways in the sense of co-production of knowledge, as Sue said. Global health is not like international health. It's not like colonial medicine. That's what's really different, this commitment, as has been noted, to equity. And mentorship is the same way. And the more we're open to learning from those we are ostensibly teaching, the more we can move forward this agenda. That can't be done only in a university in the United States. It can only be done transnationally across boundaries of class and gender and personal experience and historical experience. And that is both terrifying and exciting because global health, if it is to be really global, can't be sitting in one place. One of the other things, just to add some levity after that grand pronouncement, is that I've learned over the last 30 years, and Ann and Salman and I are all Arthur's students. By the way, Matt, you have no idea. You talk about austere, tough editor, stinting on praise. Come on, Arthur, I'm sure I'm going to get more of this from John, too, something tells me. But one thing I've learned is that everyone starts the beginning of something to the time of their own engagement. That's the quest for personal efficacy. That's not a bad thing, right? So Matt just said this course had its roots in 2008. At least let's move it back to 10 years ago, which was about when I met Matthew Frederick Basilico, who, uninvited I might add, on a plane going from Boston or Miami to Haiti. Now, he wasn't even a student at Harvard College. He just graduated from high school, and there he was on the plane, 18 years old, a skiing champion. I thought, that's going to be helpful in Haiti. And Olympic level je ne sais quoi, I didn't even know what that meant, but it was true, I might add, who was on his way to Harvard College a month later and was going to volunteer for Partners in Health. And that's how it works. People come into your life, and if you're involved in work like this, it can and should endure, and it is my hope that these connections endure permanently. Anyway, so the skiing jacket, you may have guessed that I am not on the Harvard ski team, is just a reminder to say thank you to Matt. And I had been teaching at Harvard Medical School and the Brigham and Women's Hospital since I graduated, since before I graduated 20 some odd years ago. And I was asked to come and teach a freshman seminar. I said, well, I don't know what a freshman seminar is. And then a general studies course, I also didn't know what that was. But the first and only freshman seminar I taught, Matt and Luke, and later their friends and future spouses, were involved in this same network of friends. That was a very special year. A very small group of people who, by my count, more than half of the students in that class are still working together with us in one way or another. Luke being another one of them. Now he's at Penn, defector traitor that he is. So I wore this to remind you, Matt, that it doesn't get to start where you say it starts, but when I say it starts. And the tie from John, who, again, I know is going to skewer me for my severe editing and comments in the margins. I'm ready for it. But I just want to say that if we go back to what we are calling this emerging agendas in global health equity, they've been laid out very nicely by Sue, but one of them is mentoring. How do we do that? How do we do that transnationally as a university, knowing that there are platforms for communication and teaching that couldn't exist? The cover of this book, I think, is a reminder of some of the possibilities. The top photograph is of Butaro Hospital. I'm just wondering how many of you have ever been to Rwanda and to Butaro Hospital. Butaro was a district without a hospital at all, and we've been asked by the government of the Ministry of Health of Rwanda, our mentors in teaching us, to build a hospital there. I was giving a talk a lot like this, complaining about why is it so hard to get architects and engineers to pitch in, and help us build the infrastructure we need. Why should we have to design this? And there was a student from the graduate school of design. I didn't mean to call it the graduate school of design, although your cholera centers are good, who was in the audience, Michael Murphy, and took that to heart. Later came along with some other students and professionals and designed to our specifications, not their own egomania, as is the want of most architects. This isn't being taped, is it? That was to make you laugh. Designed this beautiful hospital, and then redesigned it and redesigned it and redesigned it. And as an example of global health equity, and the challenge, I said it's both inspiring and terrifying. There's not a university in this country that is going to go and build a university in another country. I mean, there are some exceptions, but they're usually around the rather unattractive notion of extracting revenue, as was done in colonial times. That's not what this effort is about, as Sue said. It's about co-production of knowledge. And so finding partners who can build hospitals in the middle of a rural area with no electricity, Partners in Health and the Rwandan government, that's part of this challenge. And those complexities, again, have not been addressed in the past, and we're going to have to keep addressing them. By the way, another institution born out of that experience is MASS, and two of its founders are here today, and they're still doing work like that now across Africa, in Haiti, and in many other places in the world. To me, that's an example of the organic nature of this process that has to include partnerships that one wouldn't imagine. And again, our students have moved this forward. There's plenty in the book about Rwanda and Haiti and China and some about Fiji, and you're going to hear from Salman and Anne, and I'll just close by saying what are some of the emerging problems we're going to see in the future, and I just invite people to think about them. The way that they're described in this book, and by the way, this book is not a critique of cost effectiveness. Sue's ribbing me. It's basically saying that how much something costs is socially constructed, and how effective something is the measures of effectiveness are also socially constructed. That's what physician anthropologists might say, and this book was edited and taught. The course was taught by 3 physician anthropologists. In other words, both cost and effectiveness are so important, not unimportant, that we cannot leave those determinations to the adjudication of people who think they know competently how to measure cost or effectiveness. We don't. And the humility that's required to acknowledge that is really the spirit that I hope underpins this book, and why we keep on returning to social analysis and what are called in this book the socializing, resocializing disciplines, history, anthropology, sociology, etc., to complement the quantitative methods that are conventionally seen in public health. Just a couple examples of why we need to think hard about emerging agendas and to identify problems. And I can't help but praise, by the way, the chapter that Matt mentioned in passing, which is chapter 5, written by Krishna Prabhu and Luke Messick. It is, where's Krishna? Right there. Oh, come on. None of this false modesty. You're so arrogant in the classroom, I can't believe that you're faking it. By the way, not only was he tough to handle in the classroom over here, then he came to darken our days at Harvard Medical School, and then Rwanda. Now, this is my way of choking down emotion about working with students. I just want to say that chapter 5, is beautifully written. It's concise, and many have noted that concision is not my strong suit, and needed almost no editing, and it's a beautiful reminder of how inspiring this work can be. It's about AIDS activism. and what happened, which Matt mentioned. Let me just say a couple of examples and sit down. Where has that not happened? To answer that question, what are the problems before us? To answer that question, look at the burden of disease in the world. What is it? What are the leading causes of death, debility, suffering? And then ask which of these things has been addressed. Ann Becker's lecture for our course about global mental health, it's called Mind the Gap. A little wry turn of phrase about the London Tube. She's talking about the equity gap and the burden of disease. So keep thinking about burden and gap. What's our plan? Oh, Sierra, you're here too. The genius landscape architect who, instead of having me, pretend I knew which trees to plant, a real landscape architect, and I always say, I am not worthy, Sierra Bainbridge, I am not worthy. Thank you for not letting them cut down my tree. Anyway, what's our plan for breast cancer? To diagnose, to treat early, to cure? I was just talking on the way in with the surgeon, what's our plan for HCV? Hepatitis C, if there are 35 million people living with HIV, there are probably 200 million people living with hepatitis C, and we're about to see a cure introduced. Are we going to wait again and develop an equity plan 10 years from now for radically improved treatments for hepatitis C? Or are we going to get a move on and follow the pathology, burden of disease, and the gap? Now, why that's relevant in a hepatitis C in a Russian prison, why that's relevant here, I hope Salman may touch on it, I'm not sure. He'll certainly be talking about the same topics if he's looking at a biosocial analysis of MDR-TB. But that's the challenge before us. How can a university be meaningfully involved in what are fundamentally equity struggles? The answer that we've laid out in this book, but much more importantly in the network of friendships and professional relations that are our lives, answers, yes, we can be involved in creative and transformative ways in the struggles that are now facing people with both poverty and illness or lots of other problems. We have a lot of work ahead of us, not just far away, but in this country. And again, I want to thank my students, our students especially, for inspiring me and so many other people and encouraging us to teach and to write and to learn. Thank you. Thank you, Victoria Koski-Carell. That's how you pronounce it.
Hi, everyone. My name is Emily Harrison. I'm a doctoral candidate in the History of Science department and a master's student graduate from the School of Public Health, the Global Health Department there. Thank you so much. Across the past 5 years, I've been a teaching fellow in Societies of the World 25. Fortunate to be a lecturer the past couple years. Thank you very much. And I've also been fortunate to be part of this book project and the course as they were evolving together. Today, it's my pleasure to introduce Dr. Ann Becker, one of the founding faculty members of the course who inspires students year after year with her lectures on mental health in the context of globalization, metrics of global disease burden, and the problems of non-communicable disease and global health. Ann is involved in so many different aspects of the scholarship and practice of global health that I struggled to think about which way to introduce her to you. To sort of put the facts on the table, as her formal bio will tell you, she is the Maud and Lillian Presley Professor of Global Health and Social Medicine at Harvard Medical School, where she also serves as the Vice Chair of the Department of Global Health and Social Medicine. She's the former director of the Eating Disorders Clinical and Research Program at Mass General Hospital. In publishing, and has been co-editor-in-chief of the journal Culture, Medicine, and Psychiatry, and is presently associate editor of the International Journal of Eating Disorders. In federally funded research, combining her clinical and social science training, she investigates the impact of rapid economic and social transition on eating. she has done this on eating pathology, suicide, and other youth health risk behaviors in Fiji. And she's currently in the midst of a mental health research capacity building project and youth mental health pilot intervention in central Haiti. But what I would most like to highlight today in this introduction does not appear on formal bios. And this is the way Anne has inspired so many students to take seriously the problem of mental health and other burdens of that we classify as non-communicable disease in their curiosity or commitments in global health. I'm saying this as someone who's been a teacher of these students for 5 years now and has heard this come directly out of their mouths. Every year, undergraduate students tell me that Dr. Becker's critical and compassionate lectures have changed the way they think about the problems and have motivated them to bring these issues into the student groups they're part of and into the career paths they're choosing. So as a recent New England Journal of Medicine article that was co-authored by Anne and Arthur will tell you, people suffering from mental illness and non-communicable disease have historically been hugely neglected by World Health Policy priorities, research, metrics until recently, and practical assistance. It was just in the mid-2000s, not that long ago, that the claim "no health without mental health" started to gain traction in the global public health community. And it remains today a struggle to get adequate attention from major funding organizations. And yet today in 2013, for many of the students coming through this course that nurtured this textbook that we're celebrating today, the need to include mental illness and non-communicable disease in our conceptions of global health is becoming natural. This seems to me a powerful thing in the context of a broader global health movement that Anne has been contributing to at so many levels. So thank you, Anne, and please all join me in warmly welcoming Anne to speak.
Thank you, Emily, and I wanted to give you I'll give you a hug later. That was very nice. And also, I just want to, while I'm getting my slides up, which I can't possibly do myself, I want to thank the editors. I want to thank the teaching fellows, the students, mentors, some of whom are here today, for the opportunity to be here, and actually Sue and the Institute for putting this together. And it's just such a privilege to teach this course, and it's a lot of fun too. So I'm going to talk to you, as Paul alluded to, I'm going to talk to you a little bit about one of the chapters in the book, and also, as Paul alluded to, I'm going to sort of focus on metrics, because I think a lot about how do we measure suffering, what are the metrics of emotional distress. And not, as Paul alluded to, I'm not going to be so brief. Where did Paul go? In fact, you could see Salman and me exchange nervous glances when Paul said that we were all going to be brief. But I'll try. So if you'll forgive me, I'm going to talk about this chapter, which I don't even know what chapter number it is, but we'll look later, in terms of two vignettes, two ethnographic and actually quantitative data vignettes. One in Fiji, in a school-based study, and another in Haiti, in another school-based study. So here we go. And before I do that, by the way, I just want to thank my teammates, Team Haiti, Equipe Oiseau, and also friends and collaborators in Fiji. Okay, so when Sue was talking about reading through the book twice and noticing that she was feeling critiqued in some of the chapters, I was thinking to myself, I hope she's not talking about the chapter I'm going to talk about, because that wasn't intended as a critique. But our students know that we spend quite a bit of time talking about sort of an anti-reductive policy toward looking at data. So we start with the metrics, the conventional health population metrics, DALYs and YLDs. I probably should say disability-associated life years, and also years lived with disability for those acronyms. And we talk about how useful they are on the one hand, and also what are the embedded assumptions and values in these metrics, and how do we use them and also maintain our awareness of some of their limitations. But before I go there, I just want to also talk about the enormous contributions that these metrics have made to catapulting the field of global mental health to kind of center stage and recognition of the vast burden it imposes on global health everywhere. And this actually wasn't known. The global burden of mental illness really wasn't appreciated until the mid-1990s, when the global burden of disease data were published for the first time. And subsequently, a book that Arthur and others edited really framed for the global health policymakers that global mental health had been neglected for a long time, but actually comprised a substantive portion of the burden of disease. And I probably could skip the animation, because the punchline here is, in this initial global burden of disease data in 1990, you'll see that, I don't think I have a pointer, but you can see that kind of blue piece of pie over at 1 o'clock. That's the composite burden, if you use YLDs as the metric, of mental illness globally. And you'll see that it's larger than any other category of illness. So mental illnesses as a category in aggregate contribute more to the global burden of years lived with disability than any other category of disease. Paul mentioned the mind the gap, meaning that I do mind the gap. The global health and priority setting has actually seized upon these particular metrics, the DALYs and the YLDs, to make their very compelling case to rationalize more resources, services, et cetera, directed at mental health issues. And in some ways, you could really call this the gap narrative. And let me give you a few examples of that. Global mental health is, we see there's a very large burden, but it's also characterized by a series of gaps, mostly resource gaps. These are framed as financial, material gaps, and this is one illustration where you see that if you kind of look at the proportion of the burden of mental disorders compared to health burden in various economic categories of countries, compared with the health budget devoted to mental illness, you'll see there's a disproportionate spending on mental health. In addition, I think I'm frozen here. It's trying to tell me something. Okay, that's fine. I could skip that slide. The slide that I couldn't show you actually showed that the mental health providers or clinicians are in short supply across, mostly across low and middle income countries, but actually they're in short supply in our own country. This slide also shows a research gap. If you see here, the blue line is scientific publications addressing global health and infectious diseases, and on the bottom of the chart are scientific publications addressing mental disorders. And you see that you do see the hopeful inflection point about sort of a pickup in studies, but you see that mental illness is far behind. And of course, the relevance of all of these is that there's a treatment gap, and this treatment gap is especially notable in the low and middle income countries, but we have upwards of 3/4 of individuals with serious mental illness not accessing care. So then this begs the question, so these metrics have really outlined what the problem is. There's a huge burden of mental illness, there aren't enough resources, but we also teach our students to critique, again, as I said, the embedded assumptions in these metrics. And I want to take an example of a sort of a more transparent illustration of this, which is mental illness. And remember that the calculation of the burden of illness is premised on a valid assessment of diagnosis, of caseness, right? And we don't do such a great job assessing cases in the United States of psychiatric illness, and we certainly have our difficulties in assessing across socially diverse communities. And this is probably best illustrated in the multiple iterations of the DSM, which is a Diagnostic and Statistical Manual of Mental Diseases. And you see that there's DSM 1, 2, 3, 4, 5, or actually 5 is right here. And 5 just came out a few months ago, and you can see they finally went from the Roman numeral system to the Arabic system because they know they're going to go up so high. I think they're going to go to 5.1. So I wanted to talk about the field I'm in is eating disorders, and I wanted to talk just for a moment to give you an illustration of, I think of eating disorders as one of the quintessentially biosocial illnesses. And here's a snapshot of the venerable eating disorders work group who worked on DSM-5 to try to come up with the, sort of the newest, most apt, empirically supported diagnostic criteria for eating disorders. And they actually birthed a new eating disorder this time around called binge eating disorder. But that occasioned a lot of discussion around the room because if you think about it, eating disorders are this phenomenologically very diverse set of illnesses, and most of the primary symptoms occur along a dimension. And you can take any symptom, and in this case I'll take binge, and you can ask, well, what really is a binge? Who defines it and how? How is it defined here? How is it defined in Fiji, where these women are? How is it defined if you're anorexic? And I want to give you a short illustration of this, and I have to ground you in Fiji. Most people probably don't know where Fiji is, but there it is with the flag. And eating disorders don't usually come up on the public health, global health agenda, so I have to kind of frame this. So why were we looking at eating pathology in Fiji? Well, we were looking at resilience, actually. This was a community, a small-scale indigenous society that had, as far as we could tell, no indigenous category for eating disorders, was resilient against eating disorders, and which was great until a number of rapid social change ensued soon after the tourism industry was built up and electrification of villages, media, et cetera, was introduced. And we found a signal that eating disorder pathology was on the rise. And so very concerned about this, we thought, well, perhaps we should do a larger study and find out what's going on. So first we went to the community and interviewed various stakeholders. And here, this is not our focus group, but we're a group of men talking about, are you worried about eating disorders? And actually the men said, no, we're not. And they had not indeed read the DSM-4. They didn't know what eating disorders were, and they said they also didn't think, they didn't believe that they existed in Fiji. But they said, but you know what, come back and do your research, it'll be useful to us anyway, because we have some other problems there. So we thought about this issue, well, how are we going to measure eating pathology in Fiji? And we decided to do it in a school-based study, a pretty large representative sample. And I'm going to cut to the chase here and tell you that in our very large sample, we actually found that over 40% of young women were purging to control their weight. That was an unexpected finding. That is a very large percentage. It completely outmatches Massachusetts secondary schools. And we also found out that among these young women, they were also taking appetite stimulants. So something very unusual was going on, and we didn't know what. So we asked ourselves, well, these kids are very symptomatic, but we don't know, are these symptoms meaningful? And this is I'm going to use the DSM-4 here for a moment. This is kind of a chart of how prevalent various symptoms of eating disorders were. But despite the prevalence, no one actually met DSM-4 diagnostic criteria for either anorexia or bulimia nervosa. So we were sort of confused about this, and I'm going to do some hand waving here. We looked at a number of analyses, and we certainly had valid measures of eating pathology, so we did something different. We took the symptoms and we did a latent profile analysis, and we found that in fact in Fiji there was a different profile of eating disorders. And there was sort of a conventional profile too, but there was a different one, which I'll call purgative use disorder. And it turned out that that different profile was it was comparable to the conventional eating pathology in terms of what you would measure here in terms of eating pathology, and actually it exceeded the conventional disorder in terms of distress and impairment. So whatever it is we were measuring, it was real, it wasn't in the DSM-4, and it was causing people distress and impairment. But unfortunately, it was also invisible. And I make this point, I'm belaboring this point, because this is exactly the kind of thing that doesn't show up on the ledger when you're counting the number of cases that goes into your calculation for the burden of disease. And in particular here, we have a very vulnerable population, adolescent girls, who are uncounted and yet still suffering. Okay, so fast forward to 2010, the Global Burden of Disease study has come out again. Nothing has changed. Global mental illness is still tops the list in terms of years lived with disability. If you look at other kinds of metrics, such as economic losses due to mental illness, they top the chart in terms of non-communicable diseases as well. But here's the problem. We see this, we see the disparity in the burden and the resources. My colleagues and I write about it, and we just haven't gotten the traction that we need. Now, those of us who are in the room who do global health all know that we don't go into global health to belly ache about the problems, right? I mean, we do belly ache. But we also like to solve the problems. And, you know, how many articles can you write saying there's a huge burden of disease and not enough resources? Because everyone knows, well, not the pie, of course, is socially constructed, but we don't necessarily want to take resources away from other disease categories to fund mental health. We would like to find better ways, smarter ways of leveraging the resources we have. So I want to take the rest of my time to talk, to close on a more optimistic note and pragmatic note and talk about closing the resource gaps. And now I'm going to situate that in Haiti. But before I do that, I want to talk about one other thing, is that it's hard enough to identify cases and to count the cases and to know the burden of disease in certain low-resource regions. But even if you do, you could argue that in some ways it's moot. Because the kids that have the eating pathology, and in this case in Fiji there was a lot of suicidal-related behavior, they still can't access care. And if you look at psychiatrists or mental health professionals per 100,000 people in Fiji, it's abysmally low, like it is in many areas of the world. If you do the math here, you'll see that there are about 2 psychiatrists in Fiji. They may have added one since we did this analysis. But basically, you have this very dispersed 300 islands, and you have girls who are in need all over the islands, and you have all of the mental health professionals concentrated here, and yet the people who need care are there or somewhere else. It's also not going to be a solution to just train more people. This is a diagram that shows how few mental health professionals have graduated over the past academic year. We're just not going to be able to train enough people soon enough. So we have to think about a smarter way of doing things, as I mentioned, and one of the, if you listen to the chatter in the global mental health world, people are very excited about task sharing. How can we think of a new model? How can we engage other sectors, not just the health sector, but maybe the educational sector too, to deliver services to kids or their families who need it? And this thought occurred to us because in Fiji, the educators that we worked with in our school-based studies certainly had a front row seat to the youth's distress, and certainly were willing to help out. And we actually asked the question, would task sharing work in Fiji? We trained up teachers, we paired them with the students who were in distress, and our early data showed that it was feasible to do this. And so we asked ourselves the question, could we take this model and apply it elsewhere? And specifically, could we apply it in Haiti? As you all know, in 2010, there's a devastating earthquake in Haiti, and at the same time, as funds flowed into Haiti, there was greater and greater political will to consider treating the mentally ill, partly because it was self-evident that many people were affected by the catastrophic losses and trauma. So we asked the mental health team here, pictured as Zami La Santé, if we could sort of look at this together, and they gave us an enthusiastic yes. And we were fortunate to be funded by the NIMH for a capacity building grant, and even though it's framed as a research capacity building grant for a low-income country, what this really is a collaborative capacity building grant between our institution and our partners at Zami La Santé. We started off with clinical training, research methods training, and with an emphasis on the biosocial and an emphasis on understanding the limitations of reductive methods. And we moved on to community participatory data collection in focus groups with teachers, youth, their parents, to talk about what the perception of mental illness in schools was and how much of a burden it was, not just health-wise, but in terms of educational advancement for the kids. And it was clear to us that the teachers were seeing it, they didn't know how to handle it, and they wanted help. So I wanted to close on a happy note. This does end well. So last week, I had to miss class and lecture because I was in Haiti to support the mental health team there as they launched a program that they developed to train up teachers to be accompagnateurs to youth who have mental health. And the program is very simple. It's recognize, respond, and refer. And we launched it last week with a group of teachers in Haiti. The team developed this very comprehensive, like 100-plus page manual specific to teachers and working with youth and mental health. Here's a picture of the team leader, Per Eddy, and another team leader, Tatiana. I can't show you the research subjects, of course, the teachers, but they're there. And they were there enthusiastically. And Tatiana is reading little pieces of paper from the anonymous question box. And Per Eddy told me he knew it was a success because nobody complained about the food. But I knew it was a success anyway. And we've been talking a lot about empirical data. We've been talking about the need for rigorously evaluated programs. Yes, we, as global health practitioners, sometimes we don't have the solutions we want, and we jump to something that's pragmatic, but we also are mindful of the need to evaluate these solutions. So here we are with the team last week in our luxurious conference room in Hash, talking about kind of debriefing from the training. And the question, of course, is, was the training successful? Will it help this little girl? Will it help the teachers help other children? And as we always tell our students when we talk about biosocial illness, it's complicated, it's nuanced, but it's also an empirical question. And I couldn't resist. We had Meg, who I don't think is here today, just had the data in from Haiti, entered this morning. It's a first pass, but we see here that, this is not reading well in this Mac, but I'll tell you the results. The bar chart, as you can see, the lighter color bars show that there's an improvement from pre to post test, that actually knowledge increased in just a very short time after the training. These are significant differences. And you see here that some of the bars go all the way up to the top, which means 100% of the teachers answered these questions correctly. And maybe more importantly, attitudes toward mental health were significantly more positive after training. So that's just in. I'm sure there will be more. Our team is there this week launching the school-based screening part, and it will be continued. Thank you so much.
Hi, my name is John Weigel. I'm a doctoral student in political economy and government here at Harvard. I'm also a proud alum of Societies of the World 25, or Anthropology 1825. So I think of everyone who's come to the podium tonight, I'm the only actual student who took the course, and I can attest my being here is sort of a testament to how amazing it was and how much it changed my life. For 2 years, I worked as a research assistant for Paul, and I started grad school here in the fall. I also helped with a couple chapters of the book that we're here to celebrate tonight. Before I get to the reason I'm up here, which is to introduce Salman Khashoggi, I can't resist briefly adding my thanks to everyone who helped with the book, and to a few people in particular. First, of course, is Matt, who's been the architect and engine of this thing from its beginnings 5 years ago. Without Matt's vision, dedication, and passion, we wouldn't be here tonight. It's been a real honor for me to work with you on this project every step of the way. Second, Margie, you not only kept Matt from pulling his hair out most of the time, but you did an enormous amount of thoughtful and sometimes painstaking work on the book over the last few years. Many of the scintillating 93 pages of endnotes in size 9 font are thanks to Margie. Finally, I want to thank Paul, who believed in this book from the beginning. And into the book, he poured all his wisdom, his experience, and his will to raise the standard of care available to everyone on this planet. I learned so much from you while working on the book, and it was a lot of fun too. Which leads me to the reason that I'm here before you tonight to introduce Dr. Salman Khashoggi, who has been a course head for SW25 for the past 5 years, and also a major contributor to the textbook. Salman is an associate professor and director of the program in infectious disease and social change in the Department of Global Health and Social Medicine at Harvard Medical School. He's also a physician in the Division of Global Health Equity at Brigham and Women's Hospital. From 2007 to 2010, he chaired the Green Light Committee at the World Health Organization, which helps countries around the world access critically needed anti-tuberculosis drugs. So in short, Salman is an internationally renowned expert on the treatment and control of infectious disease, and in particular of drug-resistant tuberculosis. Since the late 1990s, despite near consensus among public health officialdom that treating multi-drug resistant TB was too expensive or too difficult in poor countries, Salman, Paul, and many others in this room here tonight led PIH initiatives to treat the disease in impoverished and disrupted settings, from the highlands of Lesotho to the prisons of Siberia. The success of these programs helped convince many of the naysayers, and Salman has since helped guide global health policy toward a more equitable vision. Salman is, of course, also an anthropologist who has conducted extensive field work in, among other places, Tajikistan, where he has examined the effects of post-Soviet transition on the country's health system. I'll leave these more serious topics to Salman, and in my minute left, tell a brief story that sheds some light, I think, into what makes him tick. While working on the textbook chapter on drug-resistant tuberculosis, much to my surprise, I found myself privy to a heated debate between Paul and Salman in, of all places, the margins of the manuscript pages. First, I'd get a version from Salman, blaming decision makers at the WHO for promoting policy they knew to be spreading drug resistance. Then I'd get the next version from Paul, in Paul's illegible left-handed scrawl, striking out all portions, blaming individuals, and instead railing on bureaucracy and structures of violence that perpetuate inequities in access to care. As every good SW25 student knows, it was the structure versus agency debate, raging, no holds barred in the margins of the textbook. So I tell this story to demonstrate how much the themes of this textbook animate the lives and work of people like Salman and Paul, visionary leaders who have inspired so many of us a great deal and will no doubt continue to do so here tonight. It's a true privilege to welcome Salman Khashoggi.
Wow, what an introduction. Thank you, John. I'm honored to be invited to join everyone today to celebrate this book, and I would be remiss if I didn't reflect on a bit on what Matt has said of what it was like working with Paul on the book. I made a brochure with Paul once in 1997, and it was life-altering. So I do. I now had the program that the brochure was about, which was nice, but it was life-altering. So I do feel your pain. But just so that all of you know, when I was coming here today, I was thinking, the instructions were to talk about MDR-TB and kind of relate it to the book. And as Sue has pointed out, the book is 500 pages long. And I was thinking, my God, how am I going to bring up all of these themes? I can probably talk for an hour and a half. It's going to be horrible cutting it down to 15 minutes. And I'm going to leave out so many things. And then I saw Paul, and Paul said, I hope you're not going to talk a lot. So let me try and do what I was charged to do and not talk too much. So every time I talk to people about tuberculosis, friends in places like Russia, Turkey, even Peru, and you say, they say, what do you do? And you say, I'm a TB doc. They say, oh, we still have TB? And you say, yeah, we still have it, and it's a really bad disease, and there's all these drug-resistant forms of it, and people are surprised. And they say, why? Don't we have a treatment? And we say, yeah, we have a treatment. And they say, but what's wrong? What's gone wrong? Why is it still a problem? And when you look at it, there's about 9 million people a year that have TB. About 1.7 million people die. I've purposely used a slide from 2009 because it's the last data that I sort of trust that's come out of international organizations. But you see about 500,000 people have drug-resistant TB every year. The reason I don't trust the subsequent data is because that number's gone down. And we haven't treated the disease, and it's airborne. So that's why I suspect that if the number's going down, it's an airborne disease. A friend of ours who's a banker said, it's an airborne disease and it's going down. Can that really happen? And I started thinking, wow, I can't use those numbers because even a banker is questioning them. So about 500,000 people have multi-drug resistant TB and 50,000 have what's called extensively drug resistant TB, really bad TB. And a lot of people with HIV are very prone to getting TB, and it's the biggest killer of people with HIV. So this is a major, major problem in the world. And there's a treatment regimen. You don't need to know any of these names, but there's a treatment regimen, and the backbone of which is these two drugs that are circled, isoniazid and rifampicin. And if you're resistant to those two drugs, you have multi-drug resistant TB, which requires much longer treatment than the normal short course chemotherapy, which is 6 months. So MDR TB takes 2 years to treat instead of 6 months. So it's a really big deal when you see a lot of drug resistance spreading. Now, when you think of drug resistance, there's, over the last 10 years, if you think about 500,000 people having it every year, that's about 5 million people who've had drug resistance. And about 1.5 million of those people are estimated to have just died up front. And about 3.5 million of those people, spread the disease, they eventually die. Some of them get treatment, in the private market, et cetera. And only about 0.5% in the period between 2000 and 2009 got care that we can count on as being good with good quality drugs. And this is an airborne disease that people have known about for a long time. So the questions that people ask, when you talk about being a TB doc, what is going on? What is wrong? Why are we not able to really address this disease? I think that's the topic of this book. And I want to go through that a little bit. The problem is so big that it's led even the leaders of the field of TB. You may or may not know people in this list of authors, but this is a paper from an infectious disease journal last year, and the head of the global TB program is listed here, major scientists are listed here, and basically they ask in this paper, a serious question arises: why, despite nearly 20 years of WHO-promoted activities in tuberculosis control, has the global response to the DR, drug-resistant, tuberculosis epidemic been so slow and ineffectual? And so I've spent a lot of years thinking about this since 1997 in Peru, since working on the brochure.
Is this PTSD?
It's PTSD. This is like therapy. They promised me this could be 15 minutes of therapy. And I think that we have to really start to ask this question: what's gone wrong? And for those of you that read this book, you'll see that it's a very complex answer. Part of it is biological complexity. TB is a tough disease to deal with. It's a very complex bug. It hijacks the immune system. But drug resistance has not been a big surprise for people. The TB has been at the forefront of modern medicine, modern antibiotics since the 1940s. Streptomycin, one of the first antibiotics, was created to treat TB. And it was isolated in 1943. It was shown to be effective in 1944 against Mycobacterium tuberculosis. And it was actually given to patients that same year. And what was really interesting, from the first time this drug was given, so this is 70 years ago, there was a high relapse rate. So patients got better, then they got worse immediately after. And when they took isolates from those patients, they were found to be resistant to streptomycin. So drug resistance is no surprise to anybody. It's been around from day one. And what was interesting is when they looked at the friends and relatives of people who had streptomycin resistance, they got strains that were streptomycin resistant. So it showed it could be transmitted. So it showed that even if you had these kind of mutations, the bug still had the ability to be transmitted. And in fact, in the late 1940s, there were a couple of TB drugs made. There was streptomycin. There was another drug called para-aminosalicylic acid, and this other drug that's the backbone drug, isoniazid, was made in 1951. So these drugs were brand new. They were just put on the market. Everyone didn't have access to them, and so they were not used widely. But when the British government did a survey in 1955 to check for drug resistance, they found resistance to all three of these drugs: streptomycin, isoniazid, and para-aminosalicylic acid. And they found this amongst new patients, which means it was being transmitted in the community. So drug resistance, the transmission of drug resistance, old stuff. Even the drugs themselves, these drugs that are the backbone that cause MDR-TB, the main one, isoniazid, it's been well characterized. People know exactly how it works. They know exactly how it binds. There's actually, you can do a Medline search, you'll see hundreds of papers talking about where it binds and what DNA strip it binds on, et cetera. Rifampin, the other drug, also extremely well characterized. And again, if you go to the papers, you can see exactly what the science is behind its resistance. So very, very well characterized. Treatment for this disease, extremely well characterized, because these were the old drugs that people were using. So when you get a drug-resistant strain, you have to use drugs to which it's not resistant. And there were a slew of drugs that you could use. There were studies done in the United States in the 1980s that showed how best to treat people, notably from our colleagues at National Jewish Hospital in Denver, laid out, really clear regimens. How to deliver complex care to patients. There was actually an outbreak of drug-resistant TB in New York in the late 1980s. Not the first outbreak, I might add, but the most notable outbreak, because it happened in New York and was difficult to contain. But they laid out a path of how to treat this disease, diagnosis using proper laboratories, access to drugs, of course, proper infection control, and delivery of care under direct observation, and managing people's side effects. So they laid out a really clear path. So, and there are some gaps. There's still no point of care tests, that you can go to a doctor and find out you have TB, immediately. There's still a limited number of new medicines. There's still no vaccines. But more or less, the question that people ask, why is this epidemic growing, and why is it not under control, and why don't people get care, is not because of the biology. So if it's not about the biology, then the question comes, is there some, if we can appreciate the biological complexity of this disease, and we've spent so many years studying it, is there something further that we should be looking at? And I think the answer, and this book really lays this out, is understanding the social complexity of this disease. I'm not going to go into a lot of the details, but I want to say you cannot understand why TB policy in the world has been so dismal and why we have not been able to stop this epidemic without thinking about the geopolitics of oil. And it sounds silly, but the geopolitics of oil, the Arab oil embargo in the 1970s, the recession that ensued after that, the loans that countries had to take, the debt that they picked up, are all part of the story that led to the formation of policies that were not good. I'll just elaborate a little bit. So after the Arab oil embargo and after the economies of Western countries were going down, there was obviously a reluctance to give a lot of international aid. And countries were, that had a lot of debt were having difficulty paying back money. And in the early 80s, Mexico announced that they were going to default on their debt. And it led everyone into just this complete frenzy, because it was a worry, just like we had in 2008, that the markets were going to collapse. And the International Monetary Fund entered the picture and said, we will lend to countries that are in debt if they do certain things. And one of the things that they said that they should do is to undergo structural adjustment of their economies. And for those of you that don't know what structural adjustment means, it usually means privatizing key industries, pulling back from social sector involvement, etc. And so these policies became the norm, really, for aid to developing countries in the 1980s. And it really, really defined the way that their economies moved forward, and it defined the way that their health sectors moved forward, because they were asked to divest from this. At the same time, the World Bank, there was the rise of this whole idea of cost effectiveness at the World Bank, and really the idea of saving money. And I think it's very different than what Sue is talking about when she says she uses cost effectiveness. The idea was, how do we do the minimum for the lowest amount of money? And rather than looking at an intervention and another intervention and comparing them and finding which one costs better, which one has a better value for money. So these two driving forces really shaped the way we were doing development in the 1980s, and they shaped a really important policy. They helped frame a really important policy that I think shaped TB and global health since the 1980s. So you all will recall that in 1978 there was a push to have health for all by the year 2000 at Alma-Ata in Kazakhstan. This was at a conference sponsored by the World Health Organization. And this was all happening at the same time that economies are collapsing, major problems happening, and you've got structural adjustment coming to the fore. And basically, right after Alma-Ata, a group of people get together and they say, a powerful group of people, I might add, get together at the Rockefeller Center in Bellagio, Italy. And they say, we can't do primary health care for all. It's very unreasonable in these dire economic times. Why don't we kind of narrow the scope a little bit and do something called selective primary health care? And selective primary health care was something where, they said, we'll do things with the biggest bang for their buck. and we'll, things like vaccination, things that don't require us to invest money and build up health systems and things like that. Let's do what gives us the biggest bang for the buck. We'll focus on, people that are most vulnerable, like children, et cetera. And basically, people left this meeting with the idea that, this will be an interim solution that will push, like in the future, we'll be able to move towards primary health care. Now, it's a complex story, but to sum it up, it was really bad for TB. Because when they were choosing what needed to be done, the idea was, well, let's do things that are the easiest. And TB is not easy. Even short course chemotherapy took 6 months. Diagnosing patients, there was no diagnosis. And so a paper was written by Julia Walsh here at Harvard and Kenneth Warren from Rockefeller. And basically, they laid out a strategy and priorities for disease control. And TB was a medium priority. It was, they recognized it was high prevalence, high mortality, but control was difficult. So it was not advised that countries should work on that. And more importantly, it wasn't advised that donors should fund it. And essentially, they said, these diseases like TB and African trypanosomiasis and Chagas disease, they require more research. So let's put them on hold for now. And so basically, TB fell on the back burner. I mean, the word is that, people stopped putting resources into it. The World Health Organization's TB department dropped to one person in the late 1980s. And so really it was on the back burner. There were some international organizations like the International Union Against TB and Lung Disease that kept it alive. And basically, countries of course were trying to treat it, but they didn't have this international push. And then in the late 1980s, early 1990s, as the people were thinking about different metrics to measure cost effectiveness, one of the metrics that came to the fore was the DALY, the Disability Adjusted Life Year. And the DALY, interestingly, it values people at their most productive time of life. And people who get TB, most productive in economic terms. And people with TB are usually between 15 and 45 years old, people who get TB. And so TB, the cost of doing short course chemotherapy and the productivity of the individual economically worked together to make TB one of the most cost-effective therapies. So in 1993, the World Bank rated TB as one of the most cost-effective therapies, and the World Health Organization jumped on it, and they created something called DOTS, Directly Observed Therapy Short Course. They took, they made a package of this therapy, simple therapy for TB. It actually was a very, very great plan in many ways. It made it very simple, very programmatic, and it allowed countries to roll out TB treatment to millions of people. But it was socially constructed in a certain way. It wasn't based on the science of TB. It was based on the need to fit within selective primary health care. So they had to make it simple, easy, and low cost. So there could be no nuance. There could be no fanciness. It had to just be really basic technology, really basic drugs, really basic delivery. And so they packaged this, and of course, this is the early 1990s. And it turns out that this simple, easy, low-cost thing ignores children, who are about 10 to 20% of TB patients, ignores people with HIV. You can't diagnose it well using the techniques that they wanted to use. And it ignored drug resistance. So countries were rolling out this program that was ignoring these really significant populations of people. And if you have drug-resistant TB, it's not like it just fizzles away and dies. We know from the early 1940s that it doesn't do that. So Paul actually worked on a book in 1998 with my wife Mercedes, and they mapped out all the levels of drug resistance. And so people think that drug resistance is really high right now, but from that book, just if you look 1996 in Latvia, proportion of all TB cases that were MDR-TB, so high spectrum drug resistance, 22%. India, 13%. Estonia, 11.7%. So you get the drift, very, very high drug resistance. So in response, the WHO had just launched this huge policy initiative, and countries were giving money, and people wanted it to be simple. And so the WHO said, quite honestly, in their perspective, you shouldn't treat MDR-TB because it's too expensive. So they, and they wrote this. It wasn't, these aren't just rumors from some backroom conversation. They published these things. So here's a quote: MDR-TB is too expensive to treat in poor countries. It detracts attention and resources from treating drug-susceptible disease. Or they would argue, again, very spuriously, best practice short course chemotherapy can reduce the incidence of MDR-TB where it is already endemic. So that, really making the claim that you can treat a disease for which the drugs don't work with drugs that don't work. So really, very fascinating. So I don't have time to go into this whole story, but I want to give you a taste that, this isn't about biology. Biology is important. Resistance is about biology. But the spread of resistance and the containment of resistance and who gets the resistance is about a lot of other things other than biology. So how was this contained? How was health reimagined? And I was very fortunate to have met Paul and Jim in 1994. They convinced my wife to work with them on their TV program. And so as a grad student, I was in and out of Peru a lot. So I saw the development of the Peru program. And I think that if you really sum it up, the reimagining was, let's move away from this stuff all about cost and all about whether it's worth doing something in a poor country, and let's start to think about health as a human right, as a very basic thing. Let's think about a physician's imperative to treat. Let's think about the fact that we have a patient in front of us, and I think that is, Sue put it very nicely when she used the word people. So let's think about people, and then also let's think about programmatic solutions to challenges of care delivery, whether it's in the Russian prisons, whether it's in Peru. And so this is a picture of Caraballo, one of the area where Partners in Health started an MDR-TB treatment program. And people said it's going to be impossible to treat patients in this community with this disease, and PIH did. Michael Rich, sitting right there, was part of it. Paul, of course, was part of it, and I later became part of it. But it was, literally doctors and nurses working with community health workers who lived in the village, who lived in the slum area, going house to house and looking after patients, looking after their side effects. And it turned out that it cost a fraction of what it cost in North America. So all the people who said this isn't possible because it costs too much were also wrong, morally and economically. And the outcomes were amazing. 83% cure rate, published in the New England Journal of Medicine. So let me end there. I just want to say, I think the strength of this book is to say that if we look at global health in terms solely of biology, we're making a really big mistake, because we have a lot of challenges, there's a lot of diseases, and I think that you then have to bring in a lot of the issues that are raised in the book, from bureaucracy, Paul's favorite, to politics. I didn't put agency, but agency is also a part of it, because things don't happen on remote control. But there's political economy, unintended consequences, and so I think that this book really is a way to bring all of that together. Thank you very much.
Thank you, Salman. And I know that we don't have a lot of time, and Victoria, just like Margie is now Marguerite at the medical school, has suggested that we repair to the refreshments. Is that right? And we're not in a rush. And I just want to say thank you again to all the people who contributed to this book. We hope it's useful. It's just a book, but we're all engaged long-term in this work and are hoping other people will join us as well. So the reception is right upstairs. Is that right? Thank you.